So measures of disease frequency are used to quantify disease occurrence in a particular population. You must take into account the number of people with the disease, the size of the population, and the length of time the population was followed. This diagram gives a general sense of the commonly used epidemiologic measures. These measures are useful for quantifying disease occurrence, as well as comparative methods for examining differences in the disease distribution between groups. There are three classes of mathematical parameters that are used to relate the number of cases of disease to the size of the population and to time. A ratio involves the division of one number by another number. However, the two numbers do not have to be related. A proportion is where the numerator is a subset of the denominator and is often expressed as a percentage. Finally, a rate includes time as an intrinsic part of the denominator. So once you have developed your case definition, you can then examine disease frequency in your population. The first measure we will look at is the count, which is simply the number of events. So if you're conducting a study on asthma admissions in the emergency room, the count is simply the number of patients admitted to the emergency room for asthma. A proportion is the number of events, so the count, divided by the population from which the events occurred. So if we continue with the asthma example, if we had 3 admissions to the emergency room for asthma, and there were a total of 300 patients admitted to the emergency room, the proportion of asthma patients to total patients is 1%. Rate adds the element of time. So we have the number of events, 3 admissions to the emergency room for asthma, over the population at risk, which is the 300 patients admitted to the emergency room, over the course of 1 year, which gives us 1% of asthma admissions per ER admissions per year. We typically express rates in whole numbers for a given population for a specified period of time. For example, we know that 1% of ER admissions are asthma admissions per year. We can multiply disease frequencies by a base number to give us an answer that lacks decimal places. So if we multiply the 0.01 asthma admissions per ER admissions, we get 1,000 asthma admissions per 10,000 ER admissions per year. Fixed populations usually occur when the period of observation is short, for example, passengers on an airplane for the duration of a flight. Though fixed populations are easiest to obtain when they occur over short periods of time, there are examples of fixed cohorts that occur over long periods of time. So, for example, soldiers who fought in the Persian Gulf War monitored for any cause of death for 25 years after the end of the war, assuming that the ascertainment of deaths is complete, would still be a fixed cohort because we had the entire group of people for the entire period of the study. Dynamic populations are more common than closed or fixed populations in epidemiologic research. Frequently, populations are defined by geographic area, like city, county, or state, but they can also be defined administratively, like persons enrolled in a particular health insurance plan. Incidence is simply the number of susceptible individuals who develop the disease. Susceptible individuals simply means disease-free individuals that have the potential to develop the disease. So susceptible individuals excludes those who currently have the disease since they are no longer at risk of getting it. It also excludes people who would never have the possibility of getting the disease. Cumulative incidence may also be referred to as incidence proportion or the attack rate. It is the simplest measure of incidence to account explicitly for the size of the population at risk. The time period in cumulative incidence refers to is usually fixed, specified, and the same for all members in the study population. You may also hear cumulative incidence referred to as the incidence proportion or the attack rate. It is the simplest measure of incidence to account explicitly for the size of the population at risk. The time period to which cumulative incidence refers is usually fixed, specified, and the same for all members of the study population. Cumulative incidence is easy to calculate and interpret, but it can only be measured directly in closed populations. Cumulative incidence provides a measure for the risk of developing the disease within a defined period for an average individual in the population. Now, it is usually difficult to estimate dynamic or open populations over long periods of time. So remember, dynamic populations are populations in which we are living, where the population changes all the time because people are moving in and out of the population. For example, if our population is all the women in Missouri, people move to Missouri, they move out of Missouri, people are born, and other people die. There are day-to-day changes in who would count as the population we are studying. Because it is difficult to follow each person in a dynamic population for a long period of time, we instead use the concept of person time as a more precise way to deal with the people in the population. Person time is the amount of time a person spends in your population. Incidence rate is also known as incidence density, person time incidence rate, or sometimes simply incidence. The rationale behind incidence rate is that, other things being equal, the number of new cases of disease should be proportional to the size of the population at risk and the amount of time over which susceptible individuals are observed. So computing person time allows us to account for people who enter the population after the study begins, people who are lost during the study, people who develop the disease during the study period and are no longer at risk for the disease. Now, please note that I am not going to expect you to calculate person time. I just want you to understand the reasoning behind calculating person time. So let's look at it using this graph. Person A enters the population in January and remains for the full year, so she contributes 1 year of person time. Person B enters at the beginning of the study, but develops the disease in October. So person B is no longer at risk for the disease and only contributes 0.75 years of person time. Person C enters the study at the beginning, but leaves the study disease-free in April. So person C only contributes 0.25 years of person time. Person D does not enter the study until April, but remains until the end of the year. So person D contributes 0.75 years of person time. And finally, person E enters the study in August, then develops the disease in November, therefore contributing 0.25 years of person time. Overall, we have a total of 3 person years for the study. So we can calculate the incidence rate by taking the 2 cases of incident disease, and dividing them by the 3 total person years in the study. We end up with 67 cases per 100 person years. Now, prevalence includes all prior existing cases of disease in a population, so not just the newly diagnosed cases. Sometimes you will hear prevalence referred to as point prevalence, period prevalence, or prevalence rate. However, it's important to remember prevalence rate is technically incorrect, since prevalence is a proportion. Prevalence does not have units of time, therefore it cannot be considered an actual rate. So what is the difference between incidence and prevalence? Incidence refers to the number of new cases of disease that develop in a population at risk during a defined period, while prevalence refers to the number of existing cases of disease in a population at a given time. So point prevalence refers to the proportion of people ill out of the population at one single point in time. Period prevalence refers to the proportion of people ill out of the average population for a given period of time. So that might refer to a week, a month, or a year. So let's take a moment to look at each of these cases and decide if they qualify as prevalence or incidence. Feel free to go ahead and pause the recording and look through them, try to identify them yourself, and then come back and we'll discuss. So case 1 is incidence. Specifically, it's incidence rate or incidence density. Case 2 is prevalence. Case 3 is also prevalence. The babies had the neural tube defect before they were born. So we cannot know the total number of babies at risk because we don't know the total number of conceptions. We are therefore left with the number of babies who survived to be born. We don't have the correct denominator to calculate incidence. In general, birth defects are always considered prevalence estimates. And then case 4 is cumulative incidence. Now, prevalence is a function of both the incidence of disease and the duration of the disease. So even diseases with a relatively low incidence rate can have a high prevalence at any given time if they have a long disease duration. For example, we have a high prevalence of diabetes in the United States because it is a chronic condition that people have for a long time. Now, the opposite can also be true. Diseases with short duration can have a low prevalence even if there's a high incidence because people are either cured or they die. Now, the study of mortality provides information that may prevent early deaths. It examines what are the leading causes of death, how do they differ geographically, and what are the important determinants of death. In the United States, the standard death certificate developed by the National Center for Health Statistics has been adopted by most states. There's a separate certificate for fetal deaths. The certificate requests information on demographic factors, so place of residence, occupation, age, sex, etc., as well as cause of death. It is important to note that the cause of death must be regarded with caution. It is notoriously unreliable. Frequently, multiple causes of death are entered, or the official cause of death is due to some other underlying disease process. Additionally, the physician completing the death certificate may not have been the attending physician, and therefore would not be familiar with the deceased medical history. Other sources of mortality data are available, including autopsy reports and hospital records. However, these reports are most likely not representative of the population at large. Now, the mortality rate is the most frequently used measure of mortality. It involves a defined population as the denominator, a time period, and the number of deaths occurring in the population during that time period. The crude mortality rate, or crude death rate, is simply the number of deaths that occurred divided by the number of people in the population. The crude mortality rate does not take into account the fact that the chance of dying varies according to age, sex, race, socioeconomic status, and other factors, and it is not usually appropriate for comparing different time periods or geographic areas. The case fatality rate is more specific than the crude mortality rate. The case fatality rate is simply the number of people who die divided by all the people with the disease of interest during specified time period. So let's talk about measures of comparison. Overall rate of disease in an exposed group says nothing about whether the exposure is a risk factor or a cause of disease. This can only be evaluated by comparing disease occurrence in an exposed group to another group that is usually not exposed. The latter group is usually called the comparison or the reference group. When comparing between two groups, you have two options. You can calculate the ratio of two measures of disease frequency, so a measure in an exposed group and the ratio of that to the measure in an unexposed comparison group. Or you can calculate the difference between two measures of disease frequency, a measure in the exposed group and a measure in the unexposed comparison group. Now, so far, we have learned how to calculate incidence and prevalence for populations as a whole. It is often useful to examine rates for a population as a whole to get a big picture view. However, when we only examine the big picture, we lose the ability to identify meaningful differences among subgroups of the population. For example, if you just look at the prevalence of diabetes for Missouri as a whole, you will miss the fact that the prevalence of diabetes is much higher for older age groups than it is for young adults. If we are trying to make comparisons between two populations, we will be comparing apples to oranges unless we can weed out the population differences and only examine the differences in disease rate. We use adjusted rates to essentially make all other things equal, so we truly are comparing apples to apples. So here we see the basic definitions. Crude rate is the general rate for the entire population, so that's the rate where we haven't actually done any mathematical manipulation. A stratum simply refers to the subgroup of a population. So we could have age strata, where we would have people under the age of 20, people between 20 and 40, people between 40 and 60, and so on. And each of those groupings or categorizations of age is considered a stratum or a subgroup of that population as a whole. The stratum-specific rate is simply calculating the rate for that particular subgroup of the population, as opposed to calculating for the total population. And an adjusted rate is a rate that has been mathematically manipulated to minimize the differences in the composition of populations. So it's a way we're essentially taking out the variability that's due to age, for example, and we're left with the rate differences that are only attributable to the risk factor that we're interested in. Now, what measure of disease frequency are we examining here? This is prevalence. Now, why do we consider prevalence? Because we are only looking at the number of people who had the disease at that time point. We're not looking at the number of new cases. This here is considered a crude point prevalence. It encompasses all individuals in the United States with diabetes, regardless of any demographic differences. Now remember, we talked about descriptive epidemiology a little bit earlier. We're going to review some of this. Descriptive epidemiology includes using descriptive statistics that provide information on disease patterns. Descriptive statistics are routinely collected data from many sources, including data on mortality and natality from vital records, reportable diseases from surveillance programs, other diseases from national surveys. Now, descriptive statistics are useful for providing clues about disease causation and prevention that are usually investigated further in formal studies. So we can use them for assessing the health of a population and allocating resources efficiently and targeting populations for education or preventive programs. Now, why is this important? Knowing the overall prevalence of a disease does not give us a lot of information about how the disease is distributed across different parts of the population. The stratum-specific rates allow us to look more closely at how a disease affects different demographic groups. We can calculate stratum-specific rates by first dividing our population into the subgroups. We then calculate the rate for each subgroup individually. So here we see the age-specific diabetes prevalence. So what we've done here, or what the CDC did here, was stratify the population based on age. So we have the age group of 20 to 39, the age group of 40 to 59, and the age group of 60 and above. They then calculated the prevalence of diabetes within each of those strata. We can look at the prevalence of diabetes for each defined age group and gain a lot more information about the distribution of diabetes in our population. From this figure, it's easy to see that diabetes is much more common in older adults than in younger adults. Now here we can see the percentage of adults with diagnosed diabetes broken down by age group. Notice that the prevalence of diabetes increases with age. So this is simply telling us the same thing that the graph did before. We're just seeing it in tabular format. Now we can also talk about place when we're talking about descriptive epidemiology. When we examine the distribution of diabetes by geographic location, you can see that the prevalence of diabetes differs based on where people live. Now note these are county of residence. These are distributed by county of residence, not by where the person was diagnosed. When we're talking about descriptive epidemiology, we also like to talk about time. Remember, it's person, place, and time. So we can also examine the prevalence of diabetes across time. And we can see from this figure that the prevalence of diabetes has been increasing steadily since 1996-ish. Now, why do we care? We can use descriptive epidemiology to help identify high-risk populations. We can use that information to prioritize resource allocation or to generate hypotheses for further research. Now, we can, for crude rates, we can estimate the actual disease frequency for a population, and we can use them to provide data for the allocation of health resources and public health planning. but they can be misleading if you compare them over time or if you compare them across populations. Stratum-specific rates provide more detailed information about patterns of disease frequency in different populations. We can use them to make valid comparisons across populations, but they can be cumbersome if you are trying to compare a large number of categories. Adjusting crude rates requires making a mathematical adjustment, so the resulting rates are hypothetical. They do not represent the actual disease frequency for the population, but they are more meaningful for comparisons. There are a couple of ways that we can look at standardizing rates or adjusting rates for particular factors. You're not going to need to know how to calculate standardized rates, but I do want you to see the process and understand why it's important. So the first way that we can use to standardize rates is called direct standardization. Direct standardization is also known as direct adjustment. It's a statistical procedure we use to alleviate the effects of differences in populations. The direct method uses a reference population as the basis for a comparison. So in this example, we are going to standardize based on age. The age distribution is different in each of the populations, but we want to make comparisons about the frequency of disease between the populations. So for direct adjustment, we're going to use the age distribution of a separate population. Now here we can see that the age distribution is different between the two populations. Population B is almost entirely under 45 years of age, while population A is older. If we want to make comparisons about disease frequency between the two populations, we have to make their age distribution similar. We need to hold the age distribution constant in both groups. For the direct method, we will choose to use population A as our reference population. We will then need to calculate what the rates of disease would look like in population B, should that population have the same age distribution as population A. So we can see that population A is 37.5% ages 44 and under, while population B is 93.8% ages 44 and under. So what would the case rates look like in group B if group B had the same population as the reference population, in this case population A, instead of its true population? So first, let's say that population B has the identical age distribution as population A, with 600 individuals that are 44 and under and 1,000 individuals that are 45 and older. To convert the comparison population to the distribution of the reference population, we multiply the crude rates from the comparison population, which is population B, by the number of people seen in the reference population. So if group B contained the same number of people in each age category that are present in group A, but the rate of disease frequency remains the same, we would expect to see 228 cases of disease in population B. Now that we have standardized group B to the group A population, we can make comparisons between the groups. So we can look and see that group B has more disease, especially in the over 45 age group. This was not evident when we just looked at the crude rates. Now there are times when you may be missing information that makes it impossible to use the direct method of standardization. For example, here we are missing the number of cases, and therefore the rates for each individual stratum in population B. In this situation, we would use the indirect method of standardization. In the indirect method, you essentially calculate backwards the number of expected cases in the comparison group, using the rates from a reference group and the true number of people from your population. The indirect method is more complex than the direct method of standardization. Therefore, we will not be covering the calculations in class. However, it's important to know that the indirect method exists, and there are a few key issues that you must understand. In the direct method of adjustment, we hold the age distribution constant across all comparison populations. Therefore, we can make comparisons between populations 1 and 2, 2 and 3, and 1 and 3. In the indirect method, you are not holding the age distribution constant, finding the rates based on expected number of cases calculated by using rates from a reference population. Therefore, in the indirect method, you can only make make comparisons between one population and a reference population. So this leads us to the rate ratio. So rate ratio gives information on the relative effect of the exposure on the disease. It tells you how many times higher or lower the disease risk is among the exposed as compared to the unexposed. It's commonly used in etiologic research. The risk ratio gives information on the relative effect of the exposure on the disease. It tells you how many times higher or lower the disease risk is among the exposed as compared to the unexposed. Now, the rate ratio and the risk ratio are both measures of comparison, and they are ratio measures of comparison. When we're trying to interpret these ratios, the rate or the risk ratio, a risk ratio or a rate ratio of 1 is indicative of no association between the exposure and disease. So we sometimes refer to 1 as the null value, because a ratio of 1 to 1 indicates that there's no difference between the two groups. A risk ratio or a rate ratio 2 indicates 2 times the risk of disease in the exposed compared to the unexposed. Again, remember, we're talking about a ratio, so you have to make explicit the comparisons that you're making. The exposed group compared to the unexposed group. So for example, a risk ratio of 1.6 indicates that there's 1.6 times the risk of disease in the exposed compared to the unexposed population. Or we could also say that there's a 60% increased risk of disease in the exposed population. Now, a risk ratio less than 1 indicates a protective effect of your risk factor, or your predictive factor. So a risk ratio of 0.5 indicates half the risk of disease in the exposed compared to the unexposed group, or a 50% risk reduction in the exposed. So your exposure is a protective factor as opposed to a factor that increases your risk of disease. Now we can also use difference measures to compare the disease occurrence among exposed and unexposed groups by subtracting one from the other. The risk difference, which is also sometimes referred to as the risk or the attributable risk, gives information on the absolute effect of exposure on disease occurrence. So it's the excess disease risk in the exposed group compared to the unexposed group. The public health impact of an exposure, that is, how much the disease would be prevented if the exposure were removed. This assumes that the exposure causes the disease. Now, the population risk, or the rate difference, measures excess disease occurrence among the total population that is associated with the exposure. It helps to evaluate which exposures are most relevant to the health of a target population.